Yes, hello. Okay. Greetings, dear colleagues and eminent professors. Let me introduce myself. I'm Mariam Ibrahim, a second year resident in Cairo University Hospital, and I'm honored to be here today to present to you one of the DRE cases that presented to our outpatient clinics and for your scholarly opinion about the management. Okay, so our gentleman is a 16-year-old male, left-handed. He's a student, non-significant family history. He has normal perinatal history, no NICU admissions, nothing abnormal. However, when it comes to his developmental history, the mother reported mildly delayed in motor development. She stated that he started walking at 2 years, and later on, she noticed that he started to neglect his right upper limb. His speech started at first normal as his siblings or his brothers and sisters. However, started regressing after 3 years of age in the form of slowness of speech. She also reported that he started writing slowly. Like, for example, a sentence that would take a normal child to write in 10 seconds would take him around minutes, from 6 to 10 minutes. Socially, he started regressing as well. At first in kindergarten, he had normal social status. He was friendly with people, but then he started becoming more introverted in nature. She also stated there was attention deficit. While at school, while talking to them, he started going around not paying attention without hyperactivity. Scholastic achievement was regressing as well, to the point that when he started seizing, he stopped going to school, not only because of the seizures, but she started to notice that he started paying less attention at school. He's at third grade now, being 16 years old. Of course, that's very late. He had complete vaccination history and insignificant past history. Now, speaking of the detailed semiology evolution of the patient, the mother stated that at the age of 2, something peculiar happened. She did not exactly know what it is, but she heard a scream and she rushed to see her son to find him in bilateral tonic posturing of both upper limbs. She does not remember if he was aware or not. She did not witness the onset, but she said that this tonic posturing lasted for a few minutes. She was alarmed, went to a neurologist, had an EEG done, and said that it was abnormal. She does not have that EEG now, unfortunately, but she remembers that she was started on valproic acid, around 500 milliliter twice a day, and the patient never witnessed any more seizures till the age of 4. The neurologist recommended withdrawing the anti-epileptic medication in over a year and 3 months. At the age of 4, however, she reported that the patient started falling, sudden falling, and as if he was like pulled off a carpet. So we guessed that might have been tonic seizures. That happened around 1 to 2 times a day. It lasted for a few seconds only. The patient was aware. He reports, while talking to him, I've tried to ask him, now that he's 16 years old, he does not give any idea of an aura or post-ictal phenomena back at the start of the seizures, and now as well. The attack started being followed by what I would think was myoclonic jerks. The mother reported proximal bilateral jerks in the patient's upper and lower limbs, and it was around 2 to 3 times a day, which lasted for seconds only. We'll see that in the videos later on. At the age of 12, so the patient continued to have these atonic and myoclonic, but still aware seizures till he became 12 years of age. This evolved to the patient having focal, unaware to bilateral tonic-clonic movements of all his limbs. This was noted to be usually starting right more than left, but it could happen either ways. The seizures or the events had happened of sudden onset, no preictal events whatsoever. There was no vocalization, no history of visual or sensory or olfactory auras that the patient reported to his mother, for example. Post-ictally, the mother noticed that the patient would have a headache or become drowsy for around 30 minutes. These attacks increased in frequency to become about 2 to 3 times per day for 1 to 2 minutes, and sometimes even more, 3 to 4 times. She tried multiple anti-seizure medications, which I will mention ahead, with no improvement or decrease in the seizure frequency. At 13 years of age, she was recommended starting a VNS device as some neurologist told her all of this. We did not see the patient. The patient did not come to us for all of this time. She went to another neurologist and they recommended a VNS device as they could not see anything on MRI. The MRI had been reported to be insignificant. But however, there was almost no improvement. She said that he just started to have, instead of 3 to 4 atonic or falling attacks, he started to have 2 to 3 a day. At the age of 13, he presented to us in the outpatient clinic, which is just a few months back. We requested an MRI epilepsy protocol, a PET scan, and of course a video EEG, which was done at our lab, and an IQ test. Okay, so to sum up or recap the semiology that we have, the patient's seizures started at the age of 2 years. He had multiple semiologies in the form of myoclonic, atonic, around 2 to 3 times per day, as well as separate events, which were focal to bilateral tonic-clonic, which occurred even more, around 4 times per day. The mother reported triggers of the myoclonus, such as after awakening, and more when fatigued. There was no history of clustering or status epilepticus. The longest seizure-free period throughout the history was those 2 years from the age of 2 to 4. Improvement after VNS, as I said, the mother only reported like fewer falling attacks or atonic attacks. As for the anti-seizure medication history, the patient had tried valproate, ethosuximide, zonisamide, levetiracetam, carbamazepine, vigabatrin. He only noticed, or she only noticed, improvement after taking clonazepam, but the patient is reported to sleep most of the day, so it was unhelpful. The patient is currently after the VNS on zonisamide, 100 milligrams every 12 hours. And this was his VNS parameters, the output being at 2.5 milliamperes and the duty cycle at 35%. As for the examination, the patient seemed to have subnormal mentality, but not too much. He would respond and obey, say a few sentences, but he was also very impulsive. And there are also signs of trauma, as like probably due to the tonic attacks or the sudden falling, as in like breakage of teeth and head injuries. The patient seemed to have right-sided neglect, but not weakness. On examination, it would be as strong as the left upper limb or the left limbs, but he tended not to use them, like while reaching out for objects and so on. This would be the semiology in the form of a video, home video. This is after a drop or like a tonic attack. The mother started videoing him, and we would see he might have some myoclonic. No, that's not myoclonic. There's clonic. I can see you have the right upper limb. Yes, and we have another video. Okay, so I'd asked the mother if the patient had started seizing, for example, from the left, and this is a thought paralysis of the left, or it has started with the right. She did not remember, but all we could see here is that the patient had a head drop and a right clonic movement of the upper limb. Okay. Okay, as for the EEG, Dr. Imani will start explaining about it.
He had a 24-hour record at our lab. This is his interictals. He's awake. And this is during sleep. As regards the seizure of interest, where the mother complains he jerks and falls. These are the ones we have recorded, many of them, and they occur in clusters. And occur at different intensities. This was very subtle, and then have you seen this jerk on the right, mainly on the right side? They occur in clusters. And then he had tonic seizures. Would you like to see anything in the EEG?
Were you able to capture any of his atonics?
No. I mean, he was actually sleeping. Lying supine all the time. We just captured these jerks or spasms, but we couldn't see these atonics. No. Even if they occurred, everything. These maybe subtle spasm were very subtle, but we didn't notice any atonic, and we didn't actually put him in the position where we can see it. He was he was also uncooperative and was not um, willing to sit and you know.
And interictally, there are clearly some independent left and right hemisphere, left and right temporal high voltage sharp wave disorders. So
Yeah, but I mean, it also doesn't this qualify
well,
as
not this one, but as you were going interically, there were some clearly very focal left, and yeah, so this is your focal slowing with the superimposed sharp waves, and you have just one flying right temporal or centrotemporal as well here. So yeah, so it looks like he does have independent left and right that are not necessarily synchronous at the same time.
Yes, but he has also these
Yep, bilateral synchronous. Yep.
Bilateral synchrony,
Yep.
yes.
Yep.
Would you like to see something else?
Now, the suspected area is here. On the left cingulate, like this. It's been lots of cuts, not only one cut. And I think we can see it here also in the T1 more, I think, clearly. From here to there. Yes. So do you want me to go through the images on the MRI or go through PET? Okay.
That works.
So PET, I will just show an overview. Very fast overview. So we have something on the right, not on the left, not just the left one, but I will focus here. I think this is hypo in the sulcus, on the bottom of the sulcus. What do you think?
I think the cortex is abnormal, but the uptake is normal.
Yes. So like that.
And he said he's having daily seizures every day?
Yes, almost every
Multiple
day.
daily?
Yes.
So that's something to keep in mind. And as you're looking at PET scan, if I'm having seizures while the PET scan is being taken or frequent seizures, that's actually going to do the opposite. I'm going to have hypermetabolism. So what it can make what normally would be a hypometabolic or a cold spot might look normal or might look even hypermetabolic because of that seizure. So ideally, we're talking ideally here. Yes. I'm running my PET scan with an EEG all the time. So as I'm doing my FDG, as I'm injecting my FDG, and I got to be very careful what am I using for my sedation. Propofol, I don't use things that would increase my metabolism or reduce my metabolism. So I totally agree. It seems to be normal uptake, but is it really normal, or because of the frequent seizures, it's actually making it seemingly hypermetabolic to make it look normal on the PET?
Yes. But it is abnormal in the MRI.
Right.
You agree with it?
Yeah, totally agree. I just meant to make a comment about the PET scan. How do I interpret PET scan? Because it's very important to know, was a seizure happening at the time? If I don't know how frequent the seizures are, because again, seizures can give me that hypermetabolism. So it's going to be a red spot. It's going to be a hot spot on my PET. So as I'm interpreting, I gotta keep that in consideration as I'm making my. But no, I agree. The MRI is clearly abnormal with that hyperintensity.
Mm-hmm. Okay.
Yeah. So our question here is, what would you think would be, or what would you premise would be the next step in this patient who did not respond to VNS?
I would take out the lesion.
Take out the lesion evident in the MRI.
Absolutely nothing to lose. You've got a structural abnormality that goes along with the clinical characteristics and the EEG.
Okay, then we'll have that in consideration.
100% agree. One thing I think which is worth mentioning, let's talk for 30 seconds about who should be a VNS candidate. A VNS candidate is someone who is not, and I will underscore not, a resection surgical candidate. All due respect, and I'm not pointing fingers. A patient who's a resection candidate should never get a VNS if they are a resection candidate. So, but yes, totally agree. Take out the darn thing.
I mean, I think the teaching point is that you can have what appear to be myoclonic or atonic or tonic seizures without impairment of consciousness that come from mesial frontal structures. And they are very difficult to lateralize on the EEG. I thought the EEG was a little bit more on the left than on the right, including the more subtle ictal EEG was more prominent on the left than on the right. But because it's a midline structure, the EEG can be falsely, it looks like it's bilateral synchronous, and it may be very difficult to lateralize, and your lateralization might be off. So you're looking for a midline structure abnormality to explain the child's seizures, and you found it. So then once you found it, you confirmed your hypothesis. And then the next thing to do is to take out the area. The area is not next to eloquent cortex, and the child has a high likelihood of success and low risk. Would our neurosurgical colleague agree to that?
Well, yes, I think so. It's the thing regardless. We can actually hemispheric. We can go there, and we just like can take it out. But we need a neuronavigation protocol and things like that in order to make sure. And we need a monitoring with us in order to make also sure that we already got the right spot and we completely remove it.
I think one of the things that happens with these kind of midline dysplasias is sometimes they're very discrete, but sometimes the microscopic abnormalities are much more extensive than the structural abnormalities. So I mean, you go with what you see and you use corticography to guide you. But again, this is the kind of case where you may need to go back to do a little bit more broader resection. But I think this is in the child's best interest to proceed.
So we can say that this is an example of lesional epileptic encephalopathy. You can say that this patient is lesional epileptic encephalopathy.
You can say that child has focal seizures masquerading as general seizures secondary to a known structural abnormality. Okay. I'm not so sure about the encephalopathy. I mean, he's on a lot of zanisamide.
Because the EEG, the cognition is impaired, and the EEG has a slow spike wave.
But if the slow spike wave is secondary to the lesion, then you take out the lesion, that may normalize. I think, and it's hard to me. It's hard to judge encephalopathy when someone is on relatively high doses of zanisamide.
Yeah. Thank you so much for your input. We'll probably go on that way. Thank you so much.
Please. So please let us know how people do.
Just a very quick question to the juniors in the room here. What epilepsy syndrome does that young man have? What epilepsy syndrome does he have?
Yeah, I was thinking of that. I heard that in the back.
Right? So those typically would be atonic myoclonic. He's not there. Yeah. So does he have more than one seizure type?
Yes.
Okay. Does he have developmental impairment? Does he have slow spike, slow wave? What does he have? Is Lennox-Gastaut a type of epileptic encephalopathy? Regardless, lesional or non-lesional. This.